Hello dear viewers, so I'm back with the second video on the pharmacology of heart failure. Previously, as you know, that I recorded and released a video on the pathophysiology of heart failure, as it is important to understand and discuss pathophysiology prior to the treatment options we have to deal with heart failure. So I guess you're pretty clear about the terms preload, afterload, and contractility. Just recall and refresh your past knowledge from my previous video, pathophysiology of heart failure. So just to refresh yourself, preload is the initial stretching of the cardiac myocytes before contraction or prior to contraction. Afterload is the force or load against which the heart has to contract in order to eject blood. Contractility is the stretching of the cardiac myocytes during ventricular assistance. So these are the three variables which determines the progression of heart failure. In heart failure situations, you can recall it from the past video that we have increased preload, we have increased afterload, and we have contractility problems. The defective heart cannot, pump properly, so it has contractility issues, problems. So we have to improve all of these three variables. So we have to work on these three variables. If you improve the preload, afterload, and contractility, you would be able to improve the heart failure symptoms of your patient. So congestive cardiac failure, as I'm using the term, is basically a biventricular failure. Biventricle meaning both the ventricles are failing at the same time, or one by one even. So usually the left heart failure occurs before the right heart failure, but the vice versa can occur as well, can happen as well. So finally, both ventricles fail. So this is congestive cardiac failure. So let's get started.
So we have miles to go before we sleep. So let's get started. Pharmacology of heart failure, and this is part 2. In the name of Allah, the most beneficial and magnificent. Bismillah ar-Rahman ar-Rahim and Assalamu alaikum. All right. So these are the potential therapeutic objectives in heart failure. We need to decrease preload, afterload, and we want to improve contractility if we are dealing patients with heart failure or even congestive cardiac failure. Increase in preload can be achieved by the administration of diuretics, ACE inhibitors, ARBs, and vasodilators, whereas afterload can be decreased by the administration of ACE inhibitors and ARBs. Contractility can be improved by the administration of beta-1 agonists like dobutamine, phosphodiesterase inhibitor agents like inamridone and milridones, and can also be improved by the administration of Digitalis group of drugs, which includes digoxin and digitoxin. For decreasing preload, vasodilators can be used, and here enlisted over here are the vasodilators which we used in heart failure. Top of the list we have sodium nitroprusside, also important agents for handling hypertensive emergencies. Then we have hydralazine, a famous drug for causing drug-induced SLE type of syndrome. Then we have nitrates, famous anti-angina medications. Now this thing should be kept in mind that calcium channel blockers, especially belonging to dihydropyridine group of agents like nifedipine, should be avoided in heart failure. Calcium channel blockers are negative inotropic agents, meaning they have deleterious and deteriorating effects on the contractile ability of the heart and impairs ejection fraction as well. So these agents must be avoided in heart failure because these agents further worsens the heart failure states. The mechanism of action of inotropes. On the left side, we have one of the Digitalis group of drug, that is digoxin. On the right side of this cartoon model, we have phosphodiesterase inhibitors, that is inamridone and milrinone. And down the line, we have beta-1 agonist agent, that is dobutamine. So let's start from dobutamine. Dobutamine, as we know, that it's a beta-1 agonist agent. Upon activation by dobutamine, this receptor hooks up with the GS protein. GS protein activates adenylyl cyclase enzyme, which catalyzes the conversion of ATP into cyclic AMP. Increased levels of cyclic AMP promotes the activation of protein kinase A, which opens voltage-gated calcium channels and allows the entry of calcium intracellularly. Now, increased levels of calcium are directly proportional to the contraction. Yes, cardiac myocyte contraction. So that's how these agents promote their inotropic effect and increases force of contraction of heart. Now, as I just said earlier, that on the right side we have phosphodiesterase inhibitor agents in ambrinon and milrinone. So by inhibiting phosphodiesterase enzyme, which is basically responsible for the conversion of cyclic AMP into AMP, it stops this conversion, inhibits this conversion, or blocks this conversion, and in turn increases the level of cyclic AMP. Now, the same thing will go, and same thing will happen, and increased levels of cyclic AMP will activate protein kinase A, and that will opens or activates the voltage-gated calcium channels and allows the entry of calcium and promotes muscular contraction. So that's how phosphodiesterase inhibitor agents in ambrinon and milrinone performs their inotropic effect. We will be discussing the mechanism of action of digoxin in detail in a little while. Now, as you can see on this slide, this is yet another representation of the mechanism of action of phosphodiesterase inhibitors. Phosphodiesterase inhibitors, by inhibiting the conversion of cyclic AMP into AMP, and in turn by increasing the levels of cyclic AMP, promotes the activation of protein kinase A, which in turn opens voltage-gated calcium channels and allows the conductance of calcium into the cell, meaning intracellularly. Hence, increased levels of calcium intracellularly promotes cardiomyocyte contraction, and that's how it increases force of contraction of the heart and exerts its inotropic effect. Now let's talk about Digitalis group of drugs in detail. Digitalis group of drugs are derived from a plant known as foxglove plant or Digitalis purpurea. Digitalis group of drugs are also known as cardiac glycosides and exist in two forms: digoxin, which is a more commonly used form, and the other one is digitoxin, which is less commonly used form because of its high protein binding and long half-life. So it's a longer acting agent, so it is less commonly used form of the drug. So these are the orally injectable forms available of digoxin preparation. Now let's switch gears and talk about the pharmacokinetics of Digitalis group of drugs, digoxin and digitoxin. As you can see over there that digitoxin has a high protein binding, it has a longer onset of action, and it has long half-life as well, as I just said it earlier. So it's longer acting. Whereas digoxin has a small protein binding, has a little protein binding as compared to digitoxin. It has a quick onset of action as compared to digitoxin, and has a shorter half-life as compared to digitoxin. Metabolites of digitoxin appears in the bile, whereas digoxin eliminated largely unchanged in the urine. Now this is important. Pharmacological actions of Digitalis. So this is about the mechanism of action of Digitalis. Digitalis has two types of mechanism of actions: direct actions and indirect actions. Now let's talk about the direct actions of Digitalis first. This is a cardiac myocyte, and you can see presence of lots of pumps over it. You can see sodium-potassium pump, which is responsible for pumping three sodium out in exchange for 2 potassium. You can also see sodium calcium exchanger with it, which is responsible for, pushing 3 sodium out of the cell extracellularly in exchange for calcium, and it drives its energy from the sodium potassium ATPase pump. You can also see the presence of voltage gated calcium channel, which is responsible for the conductance of calcium into the cell. What happens normally is that 3 sodium goes out in exchange for 2 potassium. Now this energy is used by this sodium calcium exchanger, and it pushes 1 calcium out of the cell extracellularly in exchange for 3 sodiums into the cell. Now when the Digitalis comes around, Digitalis hooks up with the potassium side of this pump and blocks it. So it inhibits sodium potassium ATPase pump, which results in the increased concentrations of sodium intracellularly. So hence sodium builds up inside the cell. Now the sodium calcium exchanger becomes ineffective as well, and it's no longer to push calcium out of the cell in exchange for sodium, and the calcium levels will begin to rise as well. So you have increased levels of calcium as well intracellularly. Now increased levels of calcium is basically a stimulus for the opening of this voltage gated calcium channel, and it opens and allows entry of calcium from outside to inside into the cell intracellularly. Now this high level of calcium in turn stimulates the release of calcium from the storehouse of the calcium intracellularly, which is sarcoplasmic reticulum. So sarcoplasmic reticulum also releases calcium in response to high intracellular calcium concentrations. Now this calcium hooks up with the troponin-tropomyosin complex and causes the sliding of actin over myosin. So that's how Digitalis performs its inotropic action and increases the force of contraction of the heart. So just give you a review of this mechanism one more time. Digitalis, after binding to the sodium potassium ATPase, blocks this pump, and which results in increased levels of sodium intracellularly. Now sodium calcium exchanger is no longer to drive its energy from the sodium potassium pump, which is already inhibited. Results in no longer exchange of calcium with sodium, and calcium will be retained inside the cell and its level begin to rise. Increased levels of calcium intracellularly will promote the opening or activation of voltage gated calcium channels which are present on the membranes, and on their opening they will allow more conductance of calcium into the cell. Increased levels of calcium intracellularly will promote the release of calcium from the storehouse of the calcium intracellularly, that is the sarcoplasmic reticulum. So sarcoplasmic reticulum will also release calcium in response to high intracellular calcium levels. So this calcium will now stick to the troponin-tropomyosin complex and will causes the sliding of actin over myosin. So that's how Digitalis group of drugs increases the force of contraction of the heart and exerts their inotropic effect. Now let's talk about the indirect actions of Digitalis or Digitalis group of drugs, digoxin or digitoxin. As you can see on this slide, you can see prejunctional neuron or presynaptic neuron, and on this presynaptic neuron you have presence of lots of sodium potassium ATPase pumps. Digoxin, after binding to the potassium side of the pump, inhibits it, and same thing will happen here as well. Increased levels of sodium will be accumulated intracellularly, which results in increased depolarization. Depolarization opens calcium channels and calcium rushes inside the cell and hooks up with the vesicles. In this case, vesicles contained norepinephrine neurotransmitter, acetylcholine neurotransmitter. Norepinephrine represents sympathetic autonomic nervous system, and its beta-1 receptors are present on the heart, and upon stimulation by norepinephrine, it promotes ventricular contraction. Whereas acetylcholine receptors are the muscarinic receptors present on the nodal tissue, AV and acid nodal tissue, and upon activation, acetylcholine, um, reduces AV conduction or nodal conduction. Hence, by exerting its parasympathetic autonomic nervous system effect through vagal nerves, Digitalis also improves ventricular filling by slowing the AV conduction, and also improves ventricular contraction by stimulating sympathetic autonomic nervous system. Now let's talk briefly about both mechanisms of actions of Digitalis. The main mechanism of action, or the principal mechanism of action of digoxin or Digitalis group of drugs, are to inhibit sodium potassium ATPase, whereas its indirect effect is to stimulate vagal and sympathetic activity. By stimulating the vagal activity, these drugs slows nodal conduction or AV conduction, and in turn slows the heart rate, improves ventricular filling, and finally improves cardiac output. Whereas by stimulating the sympathetic activity, these drugs exerts strong inotropic action, which is helpful, and it does it by stimulating the beta receptors and the release of norepinephrine. So that's why these drugs are more like ANS type of agents. Digoxin have a very narrow margin of safety, so closed dose monitoring is very important. It is ineffective at subtherapeutic doses, but it can give your patients arrhythmia at supratherapeutic doses. So very close dose monitoring is very important. Although important interactions with amiodarone, verapamil, diuretics, and electrolytes like potassium levels are also important, because hypokalemia predisposes to its toxicity. Its toxicity can be managed with the administration of Fab fragments or Fab antibodies, which are the antidote in case of its poisoning. Its side effects includes, after oral dose, anorexia, nausea, vomiting, abdominal discomfort, pain, and diarrhea can occur, and these are the more early signs of toxicity. The neurologic effects include headache, malaise, fatigue, drowsiness, confusion, delirium, hallucinations, or rarely convulsions. Vision can also be affected later. Blurred vision, chromatopsia, mostly for yellow and green vision, transient amblyopia or diplopia, double vision, can also occur. So this is a condition known as chromatopsia. Objects appear yellow with overdose. On the left side you have normal vision, and on the right side you can see things are appearing yellow. Gynecomastia can also occur. And at supratherapeutic doses, we are afraid of its lethal side effect, toxic side effect, which is arrhythmia production. So it can also give your patient arrhythmia. It is proarrhythmogenic as well. So now let's talk about the renin-angiotensin-aldosterone system. I told you that we will be focusing on two important medications, two key agents as far as heart failure is concerned, and we have discussed Digitalis group of agents, and now it's time to discuss ACE inhibitors and ARBs in detail. So the renin-angiotensin-aldosterone system, as you can see over there, liver is the organ which releases angiotensinogen. Now renin acts on it, which comes from the kidney, and converts into angiotensin 1. Angiotensin 1 is converted into angiotensin 2 through an enzyme known as angiotensin converting enzyme. Now, angiotensin 2 is the second best vasoconstrictor of the body, and apart from it, it also stimulates the adrenal gland to release aldosterone, which is a potent stimulator of stimulator of salt and water retentions. And it has other actions as well, which we will discover a little later. So these are the effects of aldosterone, which I was talking about, that it stimulates cardiac myocyte and causes hypertrophy as well by, um, stimulating or sensitizing the myocardium to the actions of norepinephrine. It can also induce fibroblast and causes hyperplasia. Collagen synthesis can also occur, and ultimately fibrosis can occur as well. It can cause vasoconstriction. It is a powerful vasoconstrictor as well, and it does it by stimulating angiotensin II. Now, in the kidneys, it has the effect of salt and water retentions. It causes sodium retentions and causes potassium loss through kidneys. Now, up next over here are the inhibitors of angiotensin, which includes angiotensin converting enzyme inhibitors, represented by prils in their suffix, such as captopril, enalapril, lisinopril, fosinopril. And then we have angiotensin II receptor blockers, also known as AT1 receptor antagonist or angiotensin receptor blockers, represented by sartans in their suffix, such as losartans, valsartans, candesartans. Now, as you can see on the slide, which is showing the effects of angiotensin converting enzyme, angiotensin converting enzyme is essential for the conversion of angiotensin 1 to angiotensin 2. Now, angiotensin 2 in turn has four major effects. It actually stimulates sympathetic output. It constricts vascular smooth muscle, as it is the second best vasoconstrictor of the body. Now, question arises, which one is the best vasoconstrictor of the body? I told you in my previous videos, that is, yes, vasopressin or ADH, the best vasoconstrictor of the body. Now, angiotensin 2, as you know, that it is also a potent stimulator of aldosterone release, which in turn is responsible for salt and water retentions. Now, one important effect of angiotensin 2 is that it induces or increases bradykinin metabolism. Bradykinin is basically a vasodilator, and it actually follows nitric oxide pathway, and it stimulates gonal cyclase enzyme and increases cyclic GMP levels and promotes vascular smooth muscle. Hence, angiotensin converting enzyme inhibitors, by blocking this enzyme, opposes all of these four actions of angiotensin 2. Hence, promotes the reduction in the arterial pressure and improves preload and afterload of the heart. The undesirable or unwanted effects of ACE inhibitors includes, top of the list, dry cough, which is common in around 30% of individuals taking ACE inhibitor therapy. Then your patient could be hypotensive, could become hypotensive. Hyperkalemia can occur as well, angioneurotic edema, renal insufficiency, thrombocytopenia, dysgeusia, proteinuria, and neutropenia. Whereas AT1 receptor antagonist or angiotensin 2 receptor blockers include losartans, candesartans, valsartans, irbesartans, apresartans, and telmisartans. Now let's switch gears and discuss the mechanism of action of angiotensin receptor blockers or AT1 receptor antagonist or angiotensin 2 receptor blockers. ARBs actually antagonizes angiotensin 2 by blocking angiotensin 2 receptors, mainly their subtype AT1 receptors. And by doing so, they antagonizes the effects of angiotensin 2. They do not have any effect on the bradykinin degradation. So they are not responsible for the accumulation of bradykinin. And unlike ACE inhibitors, they are not responsible for giving your patients dry cough. So these agents do not give your patients dry cough as well. So that's why when patients complain, patients who are on ACE inhibitors complains of this side effect, we usually switch over our patients from ACE inhibitors to ARBs. So ARBs, angiotensin receptor blockers, are devoid of this effect, and it is considered to be because of having no impact on the bradykinin degradation. Beta blockers saves life in heart failure. Beta blocker is the most important progress in heart failure in the past 5 years. With that, I want to thank you for watching this video, and I hope that you will get the most of it. If you have liked this video, don't forget to comment on it in the comment section, subscribe my channel, and God bless you all in this COVID-19 period. And I hope that you will pray for me, and I will be making lots and lots of interesting videos for you in future. So God bless you all. Take care. Bye-bye.